Hello everyone, this is Dr. Naz and today I'll be discussing about acute rheumatic fever. Acute rheumatic fever is the most common cause of acquired heart disease in childhood and adolescence. It is a systemic inflammatory disease triggered by pharyngitis, which is caused by group A beta hemolytic streptococci, also known as Streptococcus pyogenes. It is a type 2 hypersensitivity reaction in which the antibodies that develop against M proteins of streptococci cross-react with cardiac antigens, and it usually occurs in children of 5 to 15 years of age, and it occurs 10 days to 6 weeks after pharyngitis. The histological feature of acute rheumatic fever is a show of bodies, which is the pathognomic of the disease, and it occurs only in the heart, and it contains cardiac myofibers, and they are composed of multinucleated giant cells surrounded by macrophages and T lymphocytes. So the diagnosis of acute rheumatic fever requires Jones criteria, and it is positive if there is evidence of recent streptococcal infection plus 2 major criteria, or 1 major criteria plus 2 minor criteria. Evidence of group A beta hemolytic streptococcal infection can be obtained from positive throat culture, rapid streptococcal antigen test, elevated anti-streptolysin O titers, and recent scarlet fever. The major criteria include migratory polyarthritis, that is joint involvement, carditis, in which the myocarditis is the most common cause of death in acute rheumatic fever, subcutaneous nodules on skin, and skin rash like erythema marginatum, Sydenham chorea. The minor criteria include fever, arthralgias, elevated ESR and CRP levels, first degree AV block, that is prolonged PR interval on ECG, leukocytosis. Migratory polyarthritis is the most common initial presentation of acute rheumatic fever, and it is characterized by acute, painful and asymmetrical inflammation of joints, and it is migratory in nature, that is once it is present on one joint and then it will migrate to the other joint, then it will migrate to the third joint. It involves the larger joints, example knees, ankles, elbows and wrist. The pain characteristically responds to aspirin, and if it does not, then the diagnosis is in doubt. In heart, acute rheumatic fever can cause pancarditis, that is it can involve any of the 3 layers of heart. That is pericarditis, it can cause myocarditis, which is the most common cause of death in acute attack, and it can cause endocarditis. In acute cases of endocarditis, it can lead to mitral regurgitation, whereas in chronic cases due to persistent inflammation, it can lead to mitral stenosis. It is associated with Carey-Coombs murmur, which is a soft mid-diastolic murmur, and it is due to valvulitis with nodules on mitral valve leaflets. So this is rheumatic mitral valve with stenosis and the normal one. Subcutaneous nodule occur in 5 to 7% of the cases. They are mobile, painless nodules on extensive surfaces of joints and spine. These typically appear after more than 3 weeks of the onset of disease. Erythema marginatum. It occurs in less than 5% of cases. The lesion is characterized by red rash with raised edges and clear pale center. It occurs mainly on trunk, thighs, arms, but not on face. Sydenham chorea is the late manifestation of acute rheumatic fever. It is also known as St. Vitus dance. It appears at least 3 months after acute attack and is characterized by emotional lability followed by reversible, rapid, involuntary purposeless movements affecting all the muscles. Explosive and halting speech. 25% of the affected patient will go on to develop chronic rheumatic heart disease, and spontaneous recovery occurs within a few months. For the investigation, we require complete blood count, which may show leukocytosis. CRP and ESR levels will be elevated, and they are useful for monitoring of progression of disease. The evidence of preceding streptococcal infection can be obtained from positive throat swab culture. Anti-streptolysin O titers will be elevated, that is more than 200 units in adult and more than 300 units in children. Other investigations like chest X-ray can reveal cardiomegaly and pulmonary congestion. ECG may show first degree AV block, that is prolonged PR interval. Echocardiography can show cardiac dilatation and valvular abnormalities. For the treatment, the patient may need to do bed rest. It lessens joint pain and reduces cardiac workload, and it should be continued until symptomatic improvement, settling of fever, WBC count, and ESR and CRP levels. Analgesia is required for arthritis. Aspirin relieves the pain of arthritis. Aspirin should be continued until ESR has fallen, then gradually tapered off. Corticosteroids should be used if carditis and arthritis are severe. Corticosteroids should be continued until ESR has fallen, then it should be tapered off as well. Antibiotics are required for acute attack. Single dose of benzyl penicillin of 1.2 million unit intramuscular can be given, or phenoxymethyl penicillin 250 mg 6 hourly per oral for 10 days is also given. Penicillin allergic patient can take erythromycin, clarithromycin, clindamycin, or cephalosporins if they can take it. Chorea needs treatment with dopaminergic blockers such as haloperidol or benzodiazepines like Diazan. For secondary prevention, long-term antibiotic prophylaxis is required in selective cases. So it is required to prevent further attacks of acute rheumatic fever but does not protect from infective endocarditis. The regimes may include benzathine penicillin 1.2 million unit IM, that is intramuscular, every month, or phenoxymethyl penicillin 250 mg 12 hourly per oral, or in penicillin allergic patients, sulfadiazine 1 gram daily or erythromycin 250 mg 12 hourly daily can be given. The duration according to American Heart Association guidelines are: if there is carditis along with persistent valvular disease, then we will continue the antibiotic until 10 years after the last episode, or until at least 40 years of age, whichever is longer. If carditis is there but there is no persistent valvular disease, then continue until 10 years after the last episode, or until age of 21 years, whichever is longer. If there is no carditis or no persistent valvular disease, then 5-year prophylaxis until the age of 21 years is sufficient. Continue until 5 years after the last episode, or until the age of 21 years, whichever is long. So that's all. Thank you for watching, and if you like the video, please subscribe to my channel and comment if you need me to make video on certain topics, so I will make it.